Good morning, students. Today we will be going through biomechanics of wrist complex. Fine. And as you understand, this wrist again a complex because it is not a single joint which is responsible for the movement of the wrist. It is the there are basically two joints are there, that is the radiocarpal joint and the mid-carpal joints, which are responsible for the wrist movement. So that is why it is called as a wrist complex. Now before we start with the wrist complex, let us see the what all structures are there in wrist and hand. Now the wrist and hand, we all understand they have got 5 digits, 1 thumb, 4 fingers, 8 carpal bones, the proximal and the distal one having 4 carpals. There are 19 bones and 19 joints proximal to the or distal to the carpal. 19 bones and 19 joints. And you have each digit is having carpo-metacarpal joint, and then we also have metacarpophalangeal joints, and then we have the IP joints. It can proximal and distal, except for thumb it is having only one IP joint. Fine. So this is about the hand. Now let us start with the wrist complex. Now wrist is called as carpus and it has got two joints, radiocarpal joint and mid-carpal joint. Now if you can see from this, the radius and the carpus over here, the radiocarpal means the radius, the distal end of the radius, the scaphoid, the lunate and the triquetral. This is the one. And the pisiform is actually a very small bone which is lying or which is very floating in between. So it doesn't take part in the radiocarpal joint. So the radiocarpal joint has been formed by the distal end of the radius as well as the scaphoid, lunate and triquetral. You can see how the distal is formed, whereas the mid-carpal joint is the carpal joint between the proximal and the distal carpal rows of the wrist joint. Now do you remember the wrist joint bones? It is you can see the proximal row has scaphoid, lunate, triquetrum and pisiform. The distal row has got the trapezium, trapezoid, capitate and hamate. Can you see this? In which the boat shaped are scaphoid, and the center capitate plays a very crucial role because it becomes the axis, center point of the axis of the wrist motion. So it is a very important point. So the three important carpal bones which plays a very crucial role in wrist complex is the scaphoid, the lunate and the capitate, because the capitate is the carpal bone on which the motion takes place, whereas scaphoid and lunate will take part in the mechanics, in the arthromechanics of the joint. Fine. Now what is wrist doing? The function of the wrist is, because it is maintaining the muscle length tension relationship of forearm muscle as well as wrist and hand muscles. So for the forearm muscle for the rotational movement and hand muscle for the gripping. So it is a very crucial, again it's a mid joint, so it plays a very crucial role in the gripping also. Fine. So it is basically meant for the precision activity. It is not meant for any torque production or force production, but it is meant for the crucial or balance or mobility task or precision and manipulation tasks. Fine. So we will be covering the wrist complex under the heading like we always cover: the type of joint, the articular surfaces, the accessory structures, the kinetics and the kinematics of the joint. Fine. Now if we see, the first is the radiocarpal joint. Now the radiocarpal joint is an ellipsoidal joint. The carpal aspect has two convexities, transverse and the AP direction. Now I want to show this. What does this mean? It is an ellipsoidal variety because if you can see, I have taken the carpal, the distal end of the carpus, this radius is having what? Convexities. It is having convexities. Can you see this convexity? It is having two convexity. One is transverse and another is in AP direction. One is in transverse direction and another is in AP direction. It is having two convexities. That is why it is an ellipsoidal variety. Fine. So if you can see the distal articular surface, it is we can see it is a concavo-convex. It is biconcave curvature. Biconcave curvature, fine. And if we can see, it is having short and sharp and edges, sharp and shorter edges are there. Now it has got two facets which help, that is a lateral radial facet and a medial radial facet for the attachment of scaphoid and lunate. For the attachment of scaphoid and lunate. Fine. And it is also gives attachment. You also understand this is also attaching, this area is also attaching with the with an articular disc, because it is also taking part as a distal radio-ulnar joint. It is also a part of distal radio-ulnar joint, and the articular disc which continued as triangular fibrocartilaginous complex. We will be talking about this in detail over here. Fine. So this is the proximal area. Is the proximal area you can now see is basically a biconcave curvature is there. It has got a lateral facet for the scaphoid bone. Here is the lateral facet. The lateral facet is for scaphoid bone, and then nearby is the medial facet for the lunate, and then there is a space for the triquetrum, and the part of lunate is covered with the TFCC, that is the articular disc, that is the triangular fibrocartilaginous complex. So this is how the proximal joint surface is made up of. And this, if you can see this proximal joint surface, if you can see this, now it is an oblique surface. Now it is not straight, it is an oblique surface. Can you see? It is distal oriented. Can you see this surface? This part, if I can take as a radial styloid process, and this part is really distally placed. This is a distally placed, and it is, if seen, it is placed 12 mm below. It is placed 12 mm below than the let me show you in this form, holding the radio-ulnar joint. Can you see? It is 12 mm below the ulnar side. It is 12 mm below the ulnar side, and it is obliquely placed, and obliquely because it is not straight. Straight will be something. Now it is not straight, it is obliquely placed. And for an average, if I can say you, it is, this obliqueness is 23 degree. It is inclined towards, if you can see, this is scooping out. This is scooped out 11 degree, and it is, this notch is facing towards the ulnar to 23 degree. If I can say, the inclination of the radius towards ulnar. Now this is the shape. It is inclined towards ulnar 23 degree, and it is scooped. Scooped is as if it has you scoop an ice cream from the bar. So that is why it is scooped to that is on the volar side, it is scooped for 11 degrees. So this is how that means if I have to see this in this form, or in the alignment form, it is scooped out. It is scooped out for 11 degree. Okay, volary. So this is the proximal articular surface. Now I want to show this angle. Can you see? This is 21 degree angle. This 21 degree angle is basically, you can see it is the radial side is 23 degree facing towards the ulnar side. That is this is the angle at which it is happening. Now we have used the word called that is ulnar orientation. Now we have used the word called triangular fibrocartilaginous complex. Now this you all understand, it is basically it is the radio-ulnar joint articular disc which continues as the triangular fibrocartilaginous complex, because it continues down or it proceeds down, and it's a triangular shaped structure which arises from the ulnar styloid process, and it forms a V-shaped band. As I told you, it forms a V-shaped two bands, dorsal and volar bands, and its base is attached to this area. Its base is attached to the ulnar notch of the radius, fine. So you can see it is a triangular shaped structure, and it has got basically attachment with the ulnar styloid. It has got a point of attachment, or the apex I can say, to the ulnar styloid process, and the base is attached to the ulnar notch of the radius, and it has been supported by two laminas. The lamina, the upper lamina has got that dorsal and the volar radio-ulnar ligaments. It was attaching with the dorsal and the volar radio-ulnar ligaments, whereas the lower lamina is a thin sheath. You can say it's a thin sheath, and the lamina lower is attached to the extensor carpi ulnaris tendon, the triquetrum, the hamate, and the fifth metacarpal bone. So along with the ulnar collateral ligament. So the lower lamina is connected more as compared to the upper lamina. Upper lamina is having only the volar as well as the dorsal radio-ulnar ligament, whereas the lower lamina is basically getting connection with the extensor carpi ulnaris tendon, ulnar collateral ligament, triquetrum, hamate, and the fifth metacarpal. Fine. There is a structure called meniscus homologue. This is basically a connective tissue, or a connective tissue or a fat pad which is there in the lower lamina, and basically it is supporting or helping for the movement. So it plays a very important role. It's an irregular tissue and it varies with person to person. Now the overall function of this TFCC is that it helps in the wrist extension movement, as well as extension of the distal radius, as well as it helps to dissipate the forces from the hand, from the shoulder, elbow, and it dissipates the forces to the hand. So it is a load bearing structure, and it is a separator between the distal radio-ulnar joint and the radiocarpal joint. It is a load bearing structure, dissipates the forces, and it helps in the motion also of the wrist. So it's a very important point is this. Now this is a triangular structure. If you can see, this triangular structure is basically, it is a biconcave structure, because the structures of the distal end of the radius and ulna is concave, as well as the proximal row of carpal is also concave. So, the distal row of ulna as well as proximal row. So that is why it is a biconcave complex. It is a biconcave complex. Fine. And it is getting maximum, it has got good thickness on the periphery as compared to the center. The thickness of the periphery is helps in the movement, giving a support in the movement, whereas in the center it is not having any blood supply. So the chances of injuries or the chances of tearing of TFCC is on a higher side. Fine. Now if you can see this in this image, if you can see the fourth and the sixth, these are the palmar radio-ulnar ligament and the dorsal radio-ulnar ligament. Fourth and the sixth point is the palmar. If you can see for yourself, the fourth and the sixth is the palmar dorsal radio-ulnar ligament. Fine. And this is the extensor carpi ulnaris tendon. Fine. And this is the ulnar collateral ligament. Now this is basically, yes, this is the ulnar collateral ligament, and this is ulno. From ulna it is going up to the triquetral. So ulnar triquetral ligament, ulnar lunate ligament. Fine. You can see, and this area, this small area is the triangular fibrocartilaginous complex. And can you see this, all the structures are included in the upper and the lower lamina. The upper lamina was the palmar radio-ulnar ligament and the dorsal radio-ulnar ligament, whereas the lower are all the structures which I have mentioned here. Fine. Okay. Now this is the same view of the TFCC. Now coming to the distal part, since I don't have the wrist bones, we will be going through the slides itself. So the distal segment is having scaphoid, lunate, and triquetrum. That is the proximal carpal row. The pisiform is not taking part in it. That is, it is not in this joint. It doesn't take part in this joint. So it is basically these bones, scaphoid, lunate and triquetrum, and they are attached with their interosseous ligament, that is scaphoid, lunate, interosseous ligament and luno-triquetral interosseous ligament. They play a very crucial role in movement of the proximal row, carpal row, and we will be learning their importance, how it collapses, how it helps to collapse or prevent the collapse of proximal row. Fine. So this proximal carpal row and ligaments together appears as a biconvex cartilage covered joint surface that can change the shape to accommodate to the demands of the shape of the hand and forearm. So this is basically an incongruent kind of a joint. It is not a congruent joint, it is an incongruent kind of a joint. Therefore it allows a large range of motion also. Now when I am saying it is an incongruent joint, because it is, then if we can see is there is something very important over here, is the ulnar variance. Now what does this mean? This means that when we see the length of ulna and radius, we have already seen, we said that it is 12 mm when I am taking this joint as together. Okay, you can see this now in a better shape. Okay, now you can see this is 12 mm, then the ulna, that is the radial side is 12 mm below or inferior to that of ulna. We already said that. But what happens if this is not there? That means if the ulna is too shorter, it becomes too short than this, or if ulna is too longer than the distal end of the radius, then what will happen? If it is longer than the radius, then we say it as positive ulnar variance, and if it is too shorter than 12 mm, then we say it as ulna negative radiance. Now positive radiance, what does this mean? It means that the triangular fibrocartilaginous complex thickness depends upon it. That is whether it is positive variance is there or negative variance is there. If it is positive variance is there, it need to be, that means there is ulna is long enough, so it doesn't require that TFCC. The thickness should be very much thin, because it doesn't require it, because normally normally if we see the structure, since it is down, so it requires that thickness. It requires this kind of a thickness. But if it is something like this, it doesn't require that kind of a thickness. Okay, so TFCC and very thin layer of thickness of triangular fibrocartilaginous complex is required. Whereas in negative, when there is the short ulna is there as compared to the distal end of the radius, that requires a thick TFCC, and in that case it allows the wrist movement to take place. Fine. And there is when there is a thick kind of a thick width of a TFCC, chances of any kind of AVN is very high, because try to understand, I told you that the periphery is well vascular, whereas the center part of this TFCC is not properly vascularized. Therefore the chances of getting necrosed is very high. So you have heard of AVN of lunate, Kienbock disease. So in that condition, it is basically why this lunate is not able to get the supply, is because the TFCC central part is not getting good supply. That's why. Fine. So you can see this ulnar variance. This is the neutral position. You can see it is 12 mm down, whereas if you see here in a negative, it is very much short from 12 mm, whereas in positive you can see here in positive you can see that it is more distally placed than this. If this is the line we have to see where this is neutral, now this line is disrupted as the ulna is lagging behind. Herein the ulna is ahead, so that is why it is said to be positive. Fine. Now what about this joint capsule and ligament of the radiocarpal joint? It is basically a very strong capsule is there, but it has loose, strong but loose capsule is there. Therefore it has to be reinforced by the capsular as well as intracapsular ligaments. Fine. So the ligaments basically are the collateral ligaments, that is, it is from both the side radiocollateral and ulnocollateral ligaments, as well as the dorsal radiocarpal and palmar radiocarpal ligaments, that is one coming from the dorsal side, other coming from the palmar side. The close packed position of the radiocarpal joint is full extension, whereas the open packed position is neutral position of the wrist with little bit of ulnar deviation. Fine. Now these are the ligaments. If you can see, I wanted to show you in this form. This is the palmar radiocarpal ligament, and these are, you can see, palmar ulnocarpal, because radiocarpal is there and as well as ulnocarpal, both are there. And here you can see this is the dorsal radiocarpal ligament. Along with this there is ulnar collateral ligament as well as lateral collateral ligament. Okay, these are the 4 ligaments which are responsible for the stability. The axis of motion at the radiocarpal joint is, it has got an oblique axis. Fine, because the axis is passing through the capitate bone. Fine, so it has got an oblique head of the capitate. So the axis of rotation is oblique. You can see for the flexion and extension, the axis run medial to lateral, that is transverse axis is there. And for the interior and for the radial and ulnar deviation, it is the interior posterior axis is there. So we understand that with extension there is little bit of radial deviation, and with flexion there is little bit of ulnar deviation. Radial to ulnar. If this is the hand, it is radial to ulnar. Wrist, radial, wrist extension and radial deviation, wrist flexion and ulnar deviation takes place. Fine. Mid-carpal joints, if we see again, the next joint is the mid-carpal joint, that is articular surface. Now it is formed between, as you know, the proximal and the distal row of the carpal bones. So the proximal row was scaphoid, lunate and triquetrum, and the distal row is trapezium, trapezoid, capitate and hamate. Pisiform is not taking part in it, please note. Fine. So this is a functional unit rather than an anatomical unit, because each of this bone is having a separate capsule along with that of the carpometacarpal joint. So they are having a continuous capsules or joint capsule, fibrous and synovial lining. They are having a separate units. Fine. So it is a functional joint and rather than an anatomical joint unit, and the complex is reciprocally concavo-convex. You can see, because it is getting attached to that. So it is reciprocally concavo-convex, and the proximal row is mobile, that is the scaphoid, lunate and triquetrum is mobile and can collapse, whereas the distal row is fixed. Fine. The ligament around the mid-carpal joints are basically divided into 2 parts, which is the extrinsic as well as the intrinsic. The extrinsic means that all the ligaments which are attaching with the radius and carpal are extrinsic. Fine. The radius to carpal, ulnar to carpals, they are extrinsic ligaments. Intrinsic is within the carpals, mid carpals, that is in interconnection with the carpals, are called as intrinsic. There is one term called volar and one is called as dorsal, that is the volar area and the dorsal area. So they are basically divided as dorsal extrinsic ligaments, dorsal intrinsic ligaments, volar extrinsic ligaments, volar intrinsic ligaments. Fine. So these are like this. We will not go in so much detail, but the ligaments you should know, because they help in the stability. So you should be well aware of the terminology with you, like they are volar extrinsic, volar intrinsic, dorsal extrinsic, dorsal intrinsic. So you should understand the extrinsic word is been used when it has been, the ligaments are attaching the radius or ulna along with the carpal bones, and within the carpal bones it is called as the intrinsic ligaments. Okay, volar on the side in which it is attached. Fine. So these are the, you can see for yourself, it has got scaphololunate ligament is there, radiocollateral ligament is there, ulnocarpal ligament complex is there. Fine. So this table will tell you more. Like for the volar extrinsic ligaments, they are radioscapulocapitate, volar radiolunotriquetral, volar ulnolunate, volar ulnotriquetral, volar radioulnar ligaments. Fine. And intrinsic is scapholunate ligament, lunotriquetral ligament, and scaphotrapezoid ligament. So the dorsal extrinsic ligament is dorsal radiotriquetral and dorsal radio-ulnar ligament. Fine. So again, volar intrinsic ligaments are this, and the dorsal. Dorsal is also divided into, you can see the extrinsic part as well as the, you can see the extrinsic part as well as the intrinsic part. Extrinsic arising from the radius or ulna. Radius to luno, radius to triquetral, whereas in between the two are the, in between the carpal bones are the scaphoid, lunate, intercarpal. They come under the intrinsic part. Fine. Now these are the dorsal carpal ligaments. You can go through this. Now let us come to the function. Now it is very much important to understand, this all was the anatomy part, and my work comes here. That is what is the function of the wrist joint, how it moves. The movement of radiocarpal and midcarpal joint, that is the proximal carpal, act as a link between the radius and the carpal, radius and the distal carpals and metacarpals, to which the muscular forces are directly applied. Basically, the proximal carpal bones, the proximal carpal row, it acts as a link between the radius and ulna as well as the distal carpal row. So there is the three rows. You can understand the distal radius ulna, the proximal carpal row and the distal carpal row. So the proximal carpal row is a mechanical link between the distal radial ulna and the distal carpal row. So that is why it is called as an intercalated segment. Fine. In flexion and extension of wrist, these three proximal carpal bones, scaphoid has greatest motion and lunate moves least. The movement of the complex from complete flexion to extension are, how the movement takes place is, distal carpal row moves on the proximal carpal row, that is scaphoid, and distal carpal row on lunate and triquetrum, and then carpal as a unit move over the radius and the TFCC. I will be explaining this in detail. I have just read this slide, but I want to come to the last portion of the slide where I have explained it very well. Now again, for the radial and ulnar deviation, in radial deviation, the carpal slide ulnarly over the radius with simultaneously flexion of the proximal carpal and extension of the distal carpal. The opposite occurs in ulnar deviation. In full radial deviation, both the radio and the mid-carpal joints are in close packed position and range vary according to the wrist position. The muscles again are divided into the volar, which causes flexion, and dorsal, which causes extension. Now this is what I want to explain you. This is the distal 3 model. This is said to be the 3 segment model. Now the first row is being formed by the radius and ulna. The second row is being formed by the scaphoid, lunate and triquetrum, and the third row is being formed by the trapezium, trapezoid, capitate and hamate. So these are 3 rows. Now what happens is that when this is like this, if this is the you can see the proximal, the middle, that is the second row, and the third row. Now if I try to fold it, now what you see is the movement is, the proximal row is basically this, the second row is basically moving. Okay? The first row and the last row is in one direction, whereas the middle row is moving in opposite direction to the first and the last row. The first and the last row are moving in same direction. This is moving in opposite direction. That is, this row need to collapse so that this movement can take place. Fine. So this row need to collapse so that the movement can take place, and this collapse of the middle segment is brought about by the movement of scaphoid and lunate. Now scaphoid need to move in flexion and lunate need to move in extension so that this collapse can be controlled or this can be holded. And along with the ligaments, the scaphoid, lunate ligament and lunate triquetral ligaments, interosseous ligaments, they play a very crucial role in preventing the collapse of the proximal carpal row. telling you again that the middle row the second row need to collapse so that the movement can take place. Now this is the movement which is taking place. Now to move this, that means the first and the third to move this, the second row need to collapse, and this is holded, or this collapse has been stopped by the interosseous ligament. So if it is, then how the movement takes place? So I have given you an example for if we want to go in for the full wrist extension. So for full wrist extension, let's start with when the wrist is in full flexion. When the wrist is in full flexion, what is happening is the extensors of the wrist and the hand muscles, they activate and pull the distal carpal row. This is the distal carpal row, and it pulls the distal carpal row same in the direction of extension. That means it is moving dorsally, or it is moving where it is moving. It is moving in the dorsally, that is, it is moving in posteriorly. Fine, and it is moving in the same direction of the bone, that is the wrist extensors, they are pulling and they are moving the distal row in the same direction. Fine, but scaphoid, lunate and triquetral are not moving at all. They are holded this position, they are not moving. Only when the initial stage starts, that is from full flexion to when the initial movement starts, only the distal carpal row move in the same direction. The scaphoid, lunate and triquetrum are fixed segment, and which allows the distal carpal to glide posteriorly till the wrist comes in neutral position. From full wrist flexion to neutral position, only the distal carpal row is moving, and that too posteriorly, it is gliding posteriorly so that this movement takes place. Now from the neutral position, the scaphoid come into play. Now scaphoid starts moving along with the distal carpal row, and it comes into a close packed position. So the distal carpal row and scaphoid come into play, and they come into play, and scaphoid also start moving along posteriorly till 45 degree of extension is reached. Till 45 degree of extension is reached, and then after 45 degree of extension, scaphoid get linked with the lunate and along with the scapulolunate interosseous ligament, and they come into a close packed position till they get into full wrist extension, and they are responsible for bringing into full wrist extension. That is, the proximal and the distal row moves in on a fixed radiocarpal joint. The radiocarpal joint is totally fixed. The movement is taking place in the distal carpal row and the proximal carpal row. Now showing you again, this is full wrist flexion. We want to go into wrist extension. From the wrist flexion to the neutral position, only the distal carpal row is moving, and that too posteriorly. This is because of the action of wrist extensor group of muscles. Now from the neutral position to 45 degree of wrist extension, in this position, from neutral position, the scaphoid and the distal carpal row, they become in a close packed position, and the scaphoid also start moving in the direction of distal carpal row, that is in the posterior direction, till 45 degree of extension. Now at 45 degree of extension, scaphoid and lunate form a close packed position, and they start moving and complete the wrist into wrist extension, full wrist extension. Fine. So that means initial till neutral position, only distal row is moving, whereas from neutral position to full extension, the middle row or the proximal carpal row is bringing about the full extension. Fine. That is, there is a role of scaphoid as well as scaphoid and lunate close packed position. There is an interaction between these two, and then only this movement is taking place. Fine. So opposite will happen when the flexion will take place. Now once it is in full extension, first the capitolunate is forming, will take it to the 45 degree of extension. Then scaphoid will work along with the distal row and come into interior glide, and from neutral position again interior glide will take place at the distal row to bring about in wrist flexion. Fine. So this is the carpal movement, or the intercalated segment movement, or in the form of 3-row segment movement of wrist joint. How the wrist motion takes place. This is the wrist, I have also written the kinetics and the kinematics of the wrist complex. You can see the wrist flexion, which is round about 85 degree, and you understand it has got 2 degree of freedom, wrist flexion and extension, and abduction and adduction, or ulnar or radial deviation. You understand that with extension there is a kind of a radial deviation, whereas in flexion there is a kind of an ulnar deviation taking place, because it's a 2 joint muscle and an oblique axis is there, which is passing through the capitate bone. So primarily flexion is taking place, which is at a 85 degree range of motion. It's taking place at sagittal plane and x-axis, where the interior palmar surface of the hand is moving towards the anterior area of the forearm. This is the flexion movement. You can see the interior palmar surface of the hand is moving towards the anterior aspect of the forearm. Here what is happening at the radiocarpal joint and the mid-carpal joint, I have tried to explain it. The radiocarpal joint will roll volarly, that is, it is moving anteriorly, whereas the gliding is taking place posteriorly or dorsally. Fine. Where the distal carpal row is moving only anteriorly. It is not moving volarly, it is moving anteriorly. It has been supported by or stabilized by dorsal radiocarpal ligament, scapulolunate interosseous ligament, scapulocapitate interosseous ligament, and the muscles which come into action is flexor carpi ulnaris, flexor carpi radialis, palmaris longus. Now wrist extension, which is range is again 85 degree. It's taking place in sagittal plane x-axis, where the dorsal surface of the hand is moving towards the posterior surface of the forearm. The dorsal surface of the hand is moving towards the posterior surface of the forearm. The rolling is dorsally. You can see the rolling is posteriorly and the gliding is anteriorly, volarly. Fine, this is the movement which is taking place. The distal carpal row is also moving posteriorly. The distal carpal row in mid-carpal joint is also moving posteriorly. The stability factors are palmar radiocarpal ligament, scapulolunate interosseous, and scapulocapitate interosseous ligament. Fine, and there is muscles which are responsible is the extensor carpi radialis longus, extensor carpi radialis brevis, extensor carpi ulnaris. Now what about radial deviations? Now in deviations, which is roundabout, you can see is 15 degree. Radial deviation is less and ulnar deviation is more. This is there. So it takes place in frontal plane and AP axis. The radial deviation is only 15 degree. Here the hand is moving towards the body. Here you can see the radial deviation. The hand is moving, that is, if you can see, the lateral border is making, this lateral border is making an angle with the, if I can show it from this hand, the lateral border is making an angle with the lateral side of the arm. This is called as radial deviation. The lateral hand is moving away from the body, away from the midline of the body, and the lateral side of the hand is making an angle with the lateral side of the forearm. So the rolling is taking place radially, whereas gliding is taking place ulnarly at ulnar side on the radiocarpal joint, whereas same movement is taking place, that is ulnar side glide of distal row is taking place at the mid-carpal joints. It has been supported by ulnar collateral ligament, and the muscles are flexor carpi radialis, extensor carpi radialis longus, extensor carpi brevis. Fine. Adduction movement is the movement in which the medial side of the hand and the medial side of the forearm is making an angle, and that angle is more, that is that angle goes up to 45 degree. And okay, you are not able to see the slide. I will share the slide again. Fine. And in herein the rolling is taking place ulnar side, whereas the gliding is taking place radial side on ulnar deviation, and again the gliding is taking place on the ulnar side at the mid-carpal joint also. Radial collateral ligament is stabilizing the joint, and you can say that the extensor carpi ulnaris, flexor carpi ulnaris are the muscles responsible for this motion. Now by this I have completed the biomechanics of wrist complex, and in hand there is I won't be able to cover the anatomy part of it, because the biomechanical part is very less. It is only for the muscles, which we have already done, the explanation of how the extensor group of muscles are passing through and reaching the areas in their specific insertion area, the role of lumbricals, the role of FDS, flexor retinaculum, or the role of extensor muscles of the wrist and hand, flexor muscles of the wrist and hand, role of they are basically role, and they are the acting as an anatomical pulley, which we have already discussed in the previous videos. And I've even also told you about different forms of arches which the hand forms, or different function, precision and manipulation function, grasp and manipulation function of hand. So I won't be taking the hand complex because it is more over the anatomical part and less over the biomechanical part. So I have you will be covering it yourself, but I have covered this wrist complex because it was important, because there is a role of wrist complex, the carpal bone, which is a little bit tricky. So I try to cover it, and if you have any doubts, you can ask me or post in the comment section. Thank you.